Hello and welcome to Willow Health Media Lifeline Dialogues. This is a special episode on SHA. The last time we had such an in-depth conversation on SHA with the top leadership was at the launch of SHA. And at that time, we were talking about how this new system would work. But now we can take stock of that. And joining me for this conversation is Dr. Abdi Mohamed, who's the chairman of the Social Health Authority, and Daniel Mwai, who's a professor of economics at the University of Nairobi and the presidential advisor on health. My name is Dr. Mercy Korir, and we start from what's happening currently. And we saw Africa Uncensored that published an investigative piece. You know, Africa Uncensored, renowned investigative house about SHA and the proxy means testing, that the system was inherently overcharging, in their words, the poor. Your quick comments on that. Let me start with the Professor of Economics.
Thank you very much for having us this morning. I really believe that that is far from where the truth is. And all models have their weaknesses. But as you do the development of the model, then you correct those weaknesses to make sure that the result you get is in line with what you actually want. And what we wanted was to estimate at minimum the income of each of those households. So if you look at it, then I would say it is not an estimation of what this household should contribute. And I think as we dive in, we'll be able to explain why that is not the case.
Dr. Ali?
From the information that we have shared, the actual data vis-a-vis what was alluded, you have seen close to 90 plus are paying way below what
90%
percent plus below the 600 mark. So in terms of actual numbers, you wouldn't have that kind of number of people paying below that amount if it was overestimating the poor. And that's why when you look at it, you are not yet sure whether we are talking about the same figures or different figures. Yes.
So if you could just walk us through, like, so where's the disconnect? And I find this a bit difficult because it's sort of like your word against somebody else's word. And then we also have the document that they reference to, and page 1 says actually that the absence of new nationally representative data, there was highly likely to miscalculate means and the corresponding contributions.
So when you look at that same document, there were steps that were taken to correct that issue. First, by doing two-step modeling. Secondly, by going back to the ground, true thing for 8 counties, Nairobi being one of them.
So let's start from what was initially there. That is this document and what happened. If you can just take us step by step through that.
So the first initial steps, the data that we got from KNBS is what we used to train the model. So then when you come and look at the model, then you realize there might be some slight overestimation. So what do you do to adjust that? Is there steps that you take now to correct and one of the things that we have done is, instead of waiting for the next KNBS data, which is coming this year, 2026, so how do we go back and look at, get more data to just figure out what the model is saying vis-a-vis what is actually on the ground? And we have modeled and we have gone back to around 2,000 plus households visited physically on the ground, so that we, in 8 counties, so that we have a little bit more representative data to do this modeling. But if you look at generally, there are things that we need to talk about clearly. That the first thing that you need to realize is, for any individual in this country, all they need to do is register for them to get primary health care benefits. So they don't even need to pay a shilling. Just registration is enough to give them access to outpatient services. What does it include? Consultation, laboratory, radiology, and drugs. That, according to WHO and UNICEF declarations in Astana, would address 80% of your health needs. If you look at other institutions like the World Bank, they push that figure higher to 90%. So you have addressed 90% of your population's health needs by giving free primary health care. So what we are discussing is, how do you now address the second phase, which is inpatient and other treatments. Other treatments, what you are fighting is out-of-pocket payment. Out-of-pocket payment vis-a-vis being covered, you cannot compare. For example, one treatment for surgery, for example, which we pay 150,000 as part of your hospital bill, which covers, and a premium of 600 shilling. That one hospital bill addresses your 20-year premiums. 20-year premiums that you would have paid is equivalent to that 150,000. Imagine you paid that cash out of pocket.
It's impossible.
But you might get harambes here and there and pay. But that premium, if you had paid to social health insurance, you would have gotten cover for a whole 20 years for your whole family. So these two are the things that we need to be comparing. And for me, when I look at income from the, not informal, but I would call them the people who are not on payroll, might be haphazard. But that doesn't mean that they're not making any income. It just means that it's coming at irregular, it's not regular, at different intervals. Hence why we also addressed through the SHA lipa pole pole, meaning you don't have to pay the full amount the whole year at once. Instead, you are able to pay at daily, weekly, monthly options. All those options are available. At 600 shilling, that's 20 shilling daily, which you can pay, or 150 shilling weekly that covers you and your family. So, and that now is the second fund, which now covers for those other needs, including dialysis, cancer, surgeries, ICU. For me, that is the main gist of what we need to be comparing.
But when we say 600, if I'm not formally employed, I'm not on payroll, and maybe Mwai, you can touch on this, I naturally want to pay 300 shillings, which is the lowest.
Thank you. And I think I want to first begin by highlighting that it is sometimes sad to see people thinking that nobody thought about just having a flat value, which people can just pay.
Like what was with NHIF? It was
Yeah,
500.
like the 500 that was for NHIF, and we know that NHIF let debts. That means the optimal premium was not 500. Ideally, the optimal should be somewhere between 880 and 1040, so to speak.
1040.
Now, why we think that the mean testing offer a better solution is because it is an equalizer of the people. And why I say this is because I argue that the poor who will never come to your table here, every time you fix a value, like a figure, you disadvantage the poor. The so-called poor that the African ancestor was trying to help. You don't help them by having no mean testing. You help them by continuously improving the mean testing so that they pay based on their ability to pay. I can give you just an example with the 500 you mentioned. So if you are earning 10,000, and a lot of people earn 10,000 anyway in this country, so to speak, if you pay 500, you'll be somewhere in the range of 5% of your income, right? But it is easy to say everybody pays 500 because majority of the people making these decisions, they don't earn 10,000. Now, it is not, it doesn't make them get to see that by just fixing that 500, you raise that premium to actually above 5%. Yet, the person who is putting this law, they themselves will be paying at 2.75. So, anytime you fix a value, you disadvantage the poor people. And you go back to NHIF system that was regressive. Regressive means as the more poor you are, the higher proportion of your income you pay to this kind of a system. So that's why we are going through this struggle, all right, to perfect a model that will help the poor. The end goal is actually the same, that the people who are poor should pay based on their ability to pay, and not just say because they are informal, let us just charge them a flat rate that push the proportion to their income they are paying to be very high. So that is why the struggle is worth it. Second thing is that we look at this proximity testing as an estimator of what I would call lower bound estimate. Why I say lower bound estimate is because you underestimate the income of the rich, and you on purpose also underestimate the income of the poor. On purpose.
Underestimate
On purpose. You know that SHA would collect a little bit lesser, but it is better to err on the lower than err on an overestimation. So because that is how you smoothen, so that the welfare of a person is not lost. It is lost when overestimate, but when you are underestimating, they don't lose the welfare because they pay less, so to speak. Now, and this is also the case for the employed, because when you take 2.75 of the employed income, the first assumption you make is that is the only income they have. Okay, yeah. So you are underestimating their lowest income, which is the base that you know.
Which is on the payroll.
But we know there are other incomes, but you don't care about them. So the same way you come to when you say higher incomes are also underestimated, it's underestimated for everybody, even employed and unemployed. But it's a better way to err on that side than overcharge someone. Now, when you look at the critical issue you have raised about the process of the development, and I think this is very important. And when I look at the expose that was given or the issue that was highlighted, it touches on these things, but from an alarmist approach. Because you look at the report that they make reference to. Now, when we say we overestimate, then the second question is we go back to the data. We check, is it overestimating the poverty? Sorry, is it overestimating the contribution of the poor? The people contributing below 500 is 45%. Now, when you look at our poverty level, hardcore poverty is in the age of 25-30, 24-30, so sorry, 27 to 30. Now, normal poverty, if you look at it, is somewhere in the age of 30, 37, 35. Now, even if you give it a higher bound of 40, we are still at 45, given our data, on the people contributing the lowest. Now, economists will tell you that nobody will ever, people always underestimate their income. Like if you ask me how much I earn, I would err to the lie. I will tell you less. All right? Anytime. It's literature, it's written, it's founded. Now, you'd not expect that somebody who has gotten a premium between 300 and 500, they would want to pay 300. Even the one who have gotten, even the one who have gotten 1,000, all right, and their premium should be 2,000, they would want to pay 300. Because intrinsically humans are selfish. That's how it is. Adam Smith, basic economics. So when you look at whether people have been underestimated or not, then you go to what is called ground truthing. Now, if these people went to the report they were referring to, after the first model, we decided to go to do something called ground truthing. When you go ground truthing, is you now learn the model, but you carry the model to the specific household and you check the elements of income. Income is only estimatable through consumption. It's the best estimator. So if you are an economist and want to know how much am I earning, you will not estimate, or you will not ask me how much do you earn. You will actually count what I spend on. Because what I'm spending on is money I have. And therefore, that is how we estimate incomes. So then after you estimate it, then you come back and check, is it giving me the right results? What is the margin of error? Now, if you look at the progression of that development within the same report that was quoted, then you will see that huge improvements were done to actually correct the problem. Now, the question was, when you take a report that was part and process of development, right? You must, if we didn't want to, for instance, have this information out, then you'd have hidden the report. But you generate the report, you are open, because these are errors that are known by all statisticians. Any economist worth their salt, they will understand it. And they also know their mechanism of correcting. All right? And then introduced what we call the appeal system. Because when the model fails completely, all right, and they would say, then let somebody complain, let's appeal, then you can have a mechanism of sending somebody to actually check, because that is what will give you the real truth. But it's not how it was presented, and I feel that if they wanted their thing to be shorter, maybe if they had more time to read the report into other pages and also, take more data, I'm sure they would have given us a better pathway to improvement.
So in the final system, proximity testing, what is the percentage error such that there is an allowance for people to appeal? Or is it just that I feel it's given me 1,200 and I want to pay 300, I just appeal?
So there are several things that I would want to say. One is that the training of the model was based on between 16,000 and 30,000 households. Mm-hmm. Households. Now, that is a lot, right?
But if you compare with the total households in Kenya,
yes,
that's a fraction of it.
It is not, because I would want you to go back to research and look at how data is collected, and you realize that that's a very huge sample. When you compare the population you're dealing with, or that is an extremely huge. I actually don't think there is anyone else doing any research based on such high number of such a big sample. And when you are dealing with large sample data sets, you get a reduction in the error. That's why you go more and more and more, all right? And if you make reference to the census, then you have no sample. That means you are at full level. So we triangulated all these data that are available. And why I say we is because the people who are developing this model is not one person. There were guys from the University of Nairobi where I come from, some from Strathmore, others from WHO regional office, some of the experts like you have seen there, because nobody has an intention of underestimating or overestimating, right? So I want to first say that contrary to probably what was presented is that the issues raised were part and process of improvement of the model, so to speak. Now, the error term, or what I would say that by the last improvement, you could see it was at 90. You could check at the report. Because, I don't want to misquote, but I'm sure the last improvement was somewhere above 90.
97.9.
Correct. I think you can look at the number from the report. But even before the last improvement, I think we had already hit around 87%, right? So this improvement,
98% of the households are reclassified as low income, and approximately 2% are classified as middle income.
Yeah, and why that was coming is because we came adjusting slowly, and now to correct the problem of overestimation. All right. Now the error could still be high, but it is high on underestimation. All right. Mm-hmm. Now that's an error you work with over time because you are not now we are heading to improving the model. Mm-hmm. So you reduce that error of underestimating the income. That's the main error actually. And somebody who is rich is classified less. Even the one who is supposed to pay 800 is put at 500. The one who should be 500 is underestimated to 300. That's the underestimation we are talking, and it's an error. All right, because each person should get a precise number, but you choose where do you begin. Do you begin by being on the red, you correct the red, or do you begin on the green and then you move up? So we started with the green, and the process is actually built up. So the error of estimation then would range between the difference between the 100 and the value you are mentioning.
So in other words, you cannot have underestimation for one group and overestimation for another group.
Everyone is underestimated.
Yes. So you cannot say the rich are underestimated while the poor is overestimated in the same mathematical model. It doesn't work that way.
But I also want to highlight something for the sake of noting that remember we had data set also from social protection. Mm-hmm. And the beauty with the government, it has different data sets that you can make use of. Right? Now, bringing on board the data on
indigents,
and also triangulating it, because you need to triangulate the data with the model to also tell you how far are you in identifying who is poor and who
can't pay.
Correct. Now, those who can't pay are the ones that the government is supposed to pay for and has paid for. If you go to the Hall of Fame, you'll see the households that have been paid for in the range of 800,000 households or so, which if you want to understand it, you multiply by 4 to understand the people. It could be 2.4 million because, based on the household size in that range. Now, and the question you raised earlier, why do we have 30 million registered and less paying? Mm-hmm. All right?
Yeah.
Those are mutually exclusive things. Mm-hmm. People registering, they are registering for primary health care. It is unrelated
and emergency
with the payment.
Yes.
So, and again, Kenyans keep on asking, why could the government fund this thing? The government is funding this thing. It's just that we have a model which we call the mixed model. The government is paying for 2 main funds: the primary healthcare through the taxpayer and the emergency through the taxpayer, right? So the only one that is contributory is the one in the middle. And that's why we have a mixed model compared to when you just go to a pure government funded, and you have to also have the realities of where the state of the country was in terms of the macroeconomic indicators, and where NHIF was, where government was giving nothing. So we are in between there with a mixed model, as the chairman has explained also how the two funds are sourced.
Okay. So going back to the ground truthing, as you call it, what was the basis of the 9 counties? 1, 2,
8 counties.
8 counties that were selected.
So one is that you can learn an empirical model generally for the country, and you think country is one, and you learn one similar model. When you do that, then as the report anyway indicated, you will find that the error term will be large, because you are trying to learn a model between somebody who is earning 10,000 and a person earning 10 million. You want to learn them at the same model. So the data is spread in a very, long range. I'm trying to use things that people will not say they are complicated, but it's a very long range that you are trying to compare. So what do you do in such a case? Then you stratify your model. In stratifying, you say that I look for first the indicators that put you in a certain group of people. So that if there are people living, for instance, in Kibera, you have the people of socioeconomic characteristic of Kibera. And then you have people of socioeconomic indicators of another medium place, I don't know where, a state of medium level, and then high end like Kallen and Lavington and Kilimani. Those are and Parklands. Those are largely the richest places we have in the country, so to speak, from data. Now, from there, you learn the model in those stratas, so that you now project income based on consumptions of those bands or stratified groups that we are talking about. Now, that increases your precision and reduces your error term. And you could see that's the progress that this model followed. Because again, I've told you the kind of professors we had in the loom were serious. I can tell you for sure. Now, with that then, you go to exactly what you are asking. So after you stratify, then you learn the model. Then you look for other data sets that have also projected poverty levels. The Bureau have that kind of data, KMBS. You would also find it from the social protection data, because it's stratified and showcases poverty levels by different areas. Now, so when you project and you find that there are places you are over projecting or under projecting, then you make a decision, which one do I correct first? All right? Because it's easier to continuously correct the underestimation of income, because you get more and better data as you move to the future. So you go to do ground truthing to make sure that when you learn the model, you also go and follow that household. You identify that household you projected, and you go to check, was the projection good or bad? How far was I from the estimate when I come to the ground? Because you cannot go to all the 12 point something or 13 million households which we have in Kenya. So when you go to ground truth, you are doing two things. You are correcting new data for the sake of correcting the model. You are also correcting new data on what is my level of accuracy. Because I will see that the model is projecting this guy or this household is earning 100,000. But when you come, you realize they're actually at 300. All right? When you look at their socio-economic consumption patterns, if I may call it like that. So the ground truth was brought to actually correct the problems that were identified in page 1 of that report. All right. So that report, which this analysis or discussion was based on, these other steps came to actually correct the highlight. Because when you look at scope of work of somebody have told them, these are the issues we have identified. We want to correct them. How do we work on them? All right. If you're an expert, the expectation is you write a report. This is a scope you gave me. All right. These are my findings, and this is how they could be corrected. Now, we did ground truthing, all of us together, all right? The technical team, as well as anyone else who
the NHIF staff
was merited for that. Then we had people from the Ministry of Health. We had people from NHIF then, immediately, because we took almost 7 months or so to develop this model. It's not like somebody woke up and boom, we are in. So there was heavy participation from people who really wanted to correct it. So that ground truthing, the 2-step, as explained, the stratification of the model were just but efforts to address the problem of any form of overestimation that could occur. And then after that, we say, even with this, a model is a model. It can have, there's no model with 0 error. All right? Then provide people with appeal system. All right? So when that's why the appeal system came. That even if we know you largely lie, if you asked how much do you earn,
will not say the truth.
You will not say the truth, right? You rather estimate, all right? Largely. We still said, in case there is a chance of the error of placing you in the wrong place, then appeal. Then the other process follows.
So the 8 counties were based on poverty levels and poverty indicators.
So it's poverty levels, poverty indicators, and likelihood of an error of overestimating poverty. You see, like when you see counties, you'll see there are counties that are either far to reach or counties that have informal settings that poor people live in there. And those samples were actually also sampled in there to address that problem.
Okay. Now, so I'm seeing this 2-step model that was developed. So first, Dr. Abdi, was this what has been implemented now, or was it just sitting on the paper like this? Or is it the model that was there at first, and is it the one currently still in use?
If we used the first model, we wouldn't be speaking on these issues. We would have had more in terms of the estimation. And as we have told you, close to 40 plus % are paying below 500, which is way what they used to pay under NHIF, the fixed model fee that they were paying. So the reason why there was correction is just to make sure that you don't overestimate people's income, and put even the issue of appeal mechanism. So in terms of did you change? Yes, definitely. That's the reason why we're doing the ground truth thing. That's why we're doing all this, is just to make sure that we don't have a figure that is unbearable for people. And hence, even one step further, the lipa pole pole. All these things are meant to address the concerns and the challenges the people are facing, including that they can't pay, their income is not consistent because they are not on a payroll, so that you also have this level of easing in terms of payment.
So in the model, the low-income households are up to 15,000 shillings. Middle income is up to 100,000 shillings, and high income is from 100,000 up to above 1 million. I would have thought 100,000, say to 200,000 is middle income.
So for you, so we would have more people being overestimated.
So they should be on the middle income, because according to this, they are high income earners.
The 100,000 and
Yes.
above. Yes, if you compare, even when you look at the salary surveys, it's very few people who earn more than 100,000 and above. The bulk of workers fall below that in terms of even the formally employed. And when you look at this new model of 2.75% compared to the previous NHIF, 60% of formally employed people have gotten a reduction. Whether that reduction is 20 shilling, 30 shilling, 40 shilling, 50 shilling, they now pay less compared to what they were paying previously. Because even the previous...
The proportion that they are paying.
Yes. The 2.75 actually have reduced their premium compared to what they were paying under NHIF. The same salary,
But
different models. You are formally employed, 60% of the formally employed have gotten a reduction.
Okay. Because I was about to say, if you are at 100,000,
No.
you're paying 1.7, now you're paying 2.7.
No.
So
That's
you're
why
talking of the ones that are below
the
100.
ones who are, and that's why I'm telling you, they were the bulk. That's why the formally employed 60% have a reduction. Of course, there will be the few, the 1-2% who earn $1 million plus. Theirs have increased, which is understandable because it's now proportionate. It's no longer regressive, where one individual is paying 0.01% and another individual is paying 5%, all getting the same benefits. That is where our problem was. And this model is meant to address these issues. And I would understand the complaint generally comes from the very few who are benefiting from previous models in any reform. And they are the ones who are very well organized and have access to media. The bulk of the people who benefit from these programs, because their benefit is incremental, not much, it's not substantial. Like, you see, if I was paying 1,700 and now I'm paying 27,000, it's huge. So I'm more likely to be the one making noise because I have access to all the necessary instruments, and we are more organized and we are more united in our noise compared to the majority. The majority will benefit. Yes, it is not much substantial, but they are not as vocal as you would expect.
As the people with their gadgets and access.
Exactly.
Okay.
Exactly.
So in the PMT, the first time I went through, just checking what the PMT is and also helping a few of my staff, not the salaried ones, a few of my other staff to go through it. It had 17 questions, or was it? I think it was more. Not very many things. How many cows? How many pieces of land? Are all of these questions necessary?
So I think we are suffering from lack of information. Because remember, this informal sector person are of very different types, right? They are different types. There are questions that don't apply to you, that apply to me. But you are looking at the country. So two things I think are very important for us to first note. One is that when we started this model, actually we noted a trend. Of course, Kenyans always try to reverse engineer. It's the first thing that they try to do. You'll see in media that, if you want to get a lower premium, come to me. You see, these are people who are seated somewhere. They have a large group of people. They are trying to reverse engineer the model.
And we actually covered this from the cyber cafes that were charging 500 shillings.
Now, this is somebody who have sat down and have asked questions and have been recording over a period of time. You reverse engineer the model. It's possible All models can be non-linear. Unless you have something that you are comparing to. And that is where we have headed to. For instance, generally, people have, there is data that government have on each of these individuals. So then what you could do is to move towards improving, and that's what I'm saying, the money the informal sector is paying is far less, because even with that, right, we are not saying that we are just high because the premium is lower, right? Even with the guy seated cheating the system. But what are we doing? We are trying to also see, how do you triangulate? If you ask me my salary, and I know you don't have a way of knowing it, I'll lie. But now, if I know at the end of the month, my employer will report, there's no way of lying. That's why my 2.75 go bullet in, right?
Because we
now,
report to
yeah,
KRA.
so where Kenya is moving is to also be able to triangulate other data sets about, so that when you say, do you have income from tea, for instance, right?
I'll say no.
Then you say no, but we can check whether you sell tea.
How?
All right? Because if government has data about you on trading of tea, for instance, or coffee, or milk, or miwa, sugarcane, all right? We should get to a level where this data is brought up together. And I think this is where we have gotten some delay, all right? We should have gotten there, in my own opinion. Technically, that becomes the best triangulator. So that when you ask the question, if you are among the few Kenyans that lie, all right, on some of these things, I want to assume there are very few, my assumption, then you can say you are reporting you have no tea, but you have been selling tea at this cooperative or at this whatever. So government should move towards getting way of regulating this, so that we become fair and more fair to the employed person. Because why the employed person is not cheating is because we are using his data to determine his income. But we should also use the same for an employed person. We use their data to actually know, are you lying or are you telling the truth? Now, so I'm telling you, we have many questions because you have to use a wide range of variables. Now, if we had this data triangulation as a good thing happening in country, then the informal sector also will not lie. Because largely, remember the most poor person, the government is supposed to pay for them. Yeah. All right? The person you want to deal with is above poverty. They need government. That means when they interact with the government in one way. In a year, you'll find them interacting with the government.
Buying
right?
property.
Whatever they are doing, they buy property, they sell coffee through the government system, they sell milk through the government system, they take licenses for the small trades or whatever, but they interact with government. So those ones are the ones that are of interest. The ones that are below here, those ones are not here or there because they are poor and should be paid for by government. So the one we are dealing with is a Kenyan who have ability to pay, who has questions to fill, but want to lie. Then we should get to a way we regulate these data sets.
What would be that way?
So in other words, what Mwai is trying to tell you is we can't build the country on the sweat of the few who are employed. Everyone else must step up and participate in contributing in one way or another. And for health, for me, is for people to realize it's impossible to pay out of pocket. Even if you are rich, it's difficult. The needs of health can escalate within minutes, within an hour. 1 minute you are this, the second minute you are in ICU requiring life support. So for health, with that uncertainty, this program is meant to address those kind of issues. So the more people participate and pay up, the more the benefits are enhanced. The more now we can add more conditions, more treatment, more benefits into the system. And that's the only way that we will be able to achieve UHC.
So
And
what would be this way of making sure you get that group of people who can pay but don't want to pay? What would be that one?
The one
way
thing. The one thing is once the Court of Appeal decides that case, because there's one clause that's still stuck in the courts, unfortunately, which stopped us from doing mandatory enrollment and contribution. So once we have that case decided, then we'll be able to move into that direction of that you must contribute in one way or another. Yes.
So there's been, questions about there are very few contributing 5 million, and
Yes.
you have 29 million as of the last official announcement of the registered members, and that, those 5 million carrying the backs of the fee around 24 million
Okay.
is not fair and is sort of like a telltale sign that, SHA is not sustainable in any way.
Okay. So the first thing I think Dr. Mwai alluded earlier, the number of people registered vis-a-vis the number of people contributing, they are not related. They are mutually exclusive things, completely. Why do I say so? As I have told you, the 30 million people who are registered are people who are entitled to primary health care. So they are entitled to free primary health care that is tax funded. So when people say, oh, why is government also not paying for this? It's paying because that is tax funded. As I have told you again, that primary health care addresses between 80 to 90% of the health needs of the population over their lifetime. So basically, you have addressed the health needs of your population, 80 to 90% of their health needs. So what you are grappling with is 10%. The 30 million also includes principal members, dependents, both spouses and children. So it's not just 30 million principal members. So meaning even the people who have registered for PHC only, they have added their children, they have added their spouses. So they have a whole household benefiting from PHC, and they are not contributing to the second layer of the fund, which is SHIF, which is equivalent to NHIF. So the first things, now Kenyans have access to healthcare, which previously they did not have to under NHIF unless they were paid up. Now, for you now to reach that level of paid up is you have to contribute to SHIF. And only people who contribute benefit from that fund.
But everyone benefits from primary
health care
and the emergency.
So meaning I have to be a member, registered, and a paid up for me to benefit. So if even one person pays under SHIF and 29.9 million don't pay, it's only this one person we will cover for SHIF. The rest will cover you under PHC and emergency.
So out of the 5 million, so you're saying the 5 million are households. So what's the breakdown of the 29 million? Because you say it's
so you will have
children.
within the 29 million, 30 million, almost 10 million are children, are dependents.
So that's 1/3.
Yes.
Around 30%.
Yes, already are children that you're talking about. So won't pay, can't pay. No amount of can't pay in any way. So even if you wanted them, they can't. Yes, and they shouldn't. by law even pay, because they have principal members who are able to pay on their behalf. So that's why these many figures, it's not one group carrying the other. There's no one who is carrying anyone. If you are a principal member, you are just carrying your family, your spouse and your children. You are not carrying any other Kenyan, because every other Kenyan will have to join you in paying and contributing to this basket called SHIF. And that's where our challenge arises for people not understanding.
Mwai is itching to say something.
So I just want to support or chip in what the chairman is saying. In Kenya, these private insurances, there is none, I think, that has above a million. None.
And almost all of them combined is a maximum of 2 million.
So I'm just saying there is none above a million. Why is it that we are not saying they are not sustainable? If we have split 2 million across all of them. It's because when it comes to the social authority, because of the way it is reported and the reporter themselves don't take time to understand it, so that they give the people the right information, they bring the 30 to the 5. Then they say the 5 is carrying the 30, right? Why is it that when we are saying the 2 million of private insurances are carrying the 51 million Kenyans who are not in the insurance? Because it doesn't work like that. The 5 million are a social insurance itself. So the question is there a promise to the 5 million that they were to be treated, okay, and they paid a certain tariff, which is gazetted, and they were not paid? Now, that's a discussion that we should be having. Because when you join in, you come in with a package. Because of the earlier problems that were highlighted in the NHIF We Want report of 2019, is that people did not know their entitlement. How did we correct it now? We said publish these tariffs and entitlement so that people can get them anywhere. You can check, what am I entitled for? So I want to say that the 5 million alone is the largest insurance Kenya has ever had, number one. The 5 million, if around, I know they have
dependents.
There are 5 to 7 right, million households that have been paying. Now, that 5, if we were to post there, it is the largest insurance Kenya has ever had. It is more than twice the whole of the private sector insurance. All right? Now, if the private sector insurance is sustainable with the 2 million, then I don't understand the logic of a learned person who has done research and can do. You can choose to error yourself. See, like error of design. Yeah. So you can error in design by choice to actually report the wrong thing. So that 5 million to 7 million paying is actually at household level. The most important thing also is that for you to understand the number of Kenyans that are covered, you need to multiply with 3.2. Is the household size.
Yes.
Right? Now, when you multiply with 3.2, the 5 million will take you to 15.
Yeah.
All right? The 7 million will take you to 21. So you have between 15 and 21 million people covered.
Paid up.
All right? Under the social insurance. And that is why it is the biggest insurance. Because the total of private insurance multiplied with the same is 6 million. But people want to take you to those side issues instead of remaining on the right track. So I want to first say that sustainability is not measured the way they want to measure by comparing a fund that is government funded. That one is on its own. It is funded by government. They should be arguing, this is the amount of money needed for primary health care. This is the one that was put in the budget. Then is it sustainable or not? Then they head to ECCIF. They do the same. They say this is what is needed for emergency. Because emergency is everybody. It's free. You don't even need to register, by the way.
Yes.
You just need to find yourself
in an emergency
situation. And your government take care of you. That's new. And it's not African, by the way. Look at the African states. There's no one who is doing this kind of thing. But we need to take Kenyans to a place where we discuss things, the good ones, all right, for the sake of maintaining them and growing them, the negative ones for the sake of improving them, because health is not just like the other thing. Anybody can get sick, right? And you don't want to when you have you are a part of the 2 million in the private sector, you are busy telling the people, don't be part of the 5. All right? But we also know for you to be the private insurance,
You have to
they
be.
ask you to must have SHA.
You must have SHA.
Right?
They pay
So
net
this
of
fellow
SHA.
was reporting and not giving a progressive thoughts. And that's why I have a problem with technically. Because me, I'm a professional. As an health economist, I would want to take my country towards growth and towards sustainable financing mechanism. I would think as a responsible journalist, I'd want to take my country forward. Right? Now, and that's what I think I am lacking. And I'm thinking that the way things are moving in Kenya, the more people become educated, some of these things will become very obsolete. Ideas that are just for whining and looking for the negative to highlight it. So highlight constructively, engage. That's where we have a problem. But just to tell you, please, when you report, because you are one of those people that are journalists and they talk to Kenyans, please let people understand there is a difference between the 30 million. It is not related to sustainability of the 5. The 5 are on their own. And they are 2.5 at minimum more in terms of coverage than all private insurance. Just to highlight, the size of what they are saying is little. So when they say that is little, then the private insurances are nothing. I mean, what can they be? I mean, you can't even compare, so to speak. Yeah.
So we have 56 million Kenyans at the minimum. So where are the other 26 million?
They haven't yet registered, but every day the registration is on average is around 20,000. But there are also people who have registered, but haven't yet updated their families. So you might find someone is registered, they haven't added their spouse, they haven't added their children. And some of these things become generally emergencies when they are at the hospital, is when they realize, oh, my child is not in my cover. And hence why we appeal to the public that please be updating your dependents, add your children, all of them. And for the first time, we don't have a limit to the number of children
and even spouses. I've seen people with 2 or 3 spouses under them,
we have
and a number of children.
we have allowed because we have accepted that we are Africans and the households can be more than one. So we are okay with that part. So update, check Afya Yangu, download the app so that you can also check how your utilization is. Go to *147 hash, check your registration status, go to your eligibility.sha.go.ke to check whether your remittance or payment is up to date. Even if you are employed, sometimes you might find your employer hasn't remitted your payment, and then you find yourself at the hospital. You have been deducted, but you haven't checked that it's your employer who hasn't remitted to SHA. So all these things are things that are within your power. From your phone, you can do all these things to just be sure.
Isn't it an offense not to remit?
That would be for the employer. We will take the necessary action, including penalties. So, but as an individual, because you just need to be alert that you have added your dependents, that you have added your spouses, that we are on the same page in terms of you are aware of what's happening with your cover.
Mwai, isn't it worrisome that for mandatory insurance, we're still missing 26 or so million Kenyans?
Yeah, so one it is. But what we have is the highest that we have ever reached. Right? So, I mean, I would, even in school, I wanted to get an A. Right? I aspired for it, I can tell you. Every time I went to the exam room. But I progressively, there are times I would not get low, I move up, I work hard until I go up. So there are two issues that you need to look at here. One is the issue of enforceability, right? And this is why there's a court that is, the case that is already in court. And what was it trying to suggest? Suggesting that I check an informal person, as a formal person, every month before they get their salary that they are at the hearing. It was saying for an informal person who has ability to pay, we know they will need government once a year at minimum. You have an enforcement area. So that has not been done. It's not because it's not doable, but it's because there is a court case.
There's a court case,
and when it is over, I'm sure we'll be able to say, like, you know, if you get in touch with the government, for instance, I have a private insurance. Why I pay, one I could be, I love my life and I don't want when I hit another car to pay. But also, my policeman will stop me and check.
And if it's,
right?
and if you have not displayed it,
Now, if I'm taking a private insurance for my car, because I'm an informal person, in that case, the example I'm giving, I'm saying an informal person who has a private insurance, the policeman would stop and check under the
insurance.
Insurance for the car.
For the car.
But the fellow inside is not insured. All right. So what we are saying is that when I come to renew my insurance, can we be allowed that you put in your SHA number to verify you have also paid for your SHA? If I'm coming to renew my business license, okay, it's okay, I'm good, I'm renewing my business license. But if I die, I will not have a business license. If I'm sick, my productivity level is low. Can I be allowed, where I am keen in to get the business license for the year, can they also check that I'm paying SHA? All right. So when we do this, we'll treat the formal and the informal the same. Because in the formal, we are checking every month. The informal, then we will be able to also check even if it's once a year. Because it's once a year, they'll be told to pay. And they say, I have no money. Okay, then they say, very nice. Ingia shali papa, pole, commit to be paying slowly until we meet next year when you'll be coming again. You should have finished paying.
So the mandatory enforcement is for the informal sector of the can pay but won't pay.
Yeah, can pay, won't pay. Because those who can pay
and won't pay
and don't pay, government should pay for them. They are poor already. They actually don't need, they have no much activity with the government. These are guys who are in abject poverty. They need uplifting to equalize, bring equity in access. So the government pays for these guys so that they come up to these ones who can pay. But these who can pay
but are not willing to
and
pay.
Are refusing to pay, it's like someone who is employed and they're refusing to remit. There's no difference because they can pay, but they are refusing
to pay.
That is the group we are talking about. This other one is clear. It's already supposed to be paid for. It's unfortunate that the socioeconomic indicators have not improved. As government and as country grow, the expectation is that their socioeconomic will increase. And you can change from can't pay, won't pay, because you have no ability. Your ability can come up.
At the same time, it can come down.
Yeah. Then there is a guy who can pay, all right, and is paying, and they can come down. The government should pick this guy, all right, so that even if they lack all the other things, they can access health benefits, and if they get an emergency, they will be picked by their government, and they'll be taken care of. That's the kind of equity we are trying to look for. And that's why the struggle. You know, nobody loves this cracking of mathematics every time. All right? It is a necessary thing for the sake of those who don't have. Because the alternative, those who have money will say a very easy statement. fix a premium. All right? And that's a no-brainer. Even as we know, fixed premium is the easiest. But when you fix it, you disadvantage the poor. But the fixer is rich. But he's pretending that he's saying fix to help the poor. But the fixing, all right,
it's actually not advantageous.
Will actually punish more poor than the ones that would be punished by a mean testing. All right? And that's why then you offer an alternative route of appeal. So that you level the ground, but don't punish somebody for an error of anywhere between 10-20% of the population being misclassified. You can appeal that one and deal with that. But don't punish the 80.
But what is the threshold for the appeal? Is it any figure? If I get 350, can I appeal because I want to go to 300? Or is there a minimum premium per month that is eligible for appeal?
Actually, we began by looking at who are in the odds of complaining. Actually, the odds of complaint is driven by the past contribution history. Right? So people had fixed their mind that because I used to contribute 500, I must contribute 500. Even when I have ability to pay more than 500. Because I have an entitlement to the 500. But the guy who is employed has no entitlement for the 1,700 because the ability is at 1 million.
So it's 27,000.
So it's supposed to be 27,000. And then you adjust this other guy, the informal sector also, if you are paying 500. All right? And we know you have 18 matatus on the road, by the way. Right? And you are making 100,000 a day or something like that. Right? So you have 3 million. But you don't want to pay your rate. You want to pay 500. So those are the people you see making a lot of noise, by the way. Then we have a group. All right? Remember the way the model is working. It is first placing you in your bucket or in your strata, if I use the right terminology. So it puts you in your strata, a strata of equals and predicting there. Now, so the odds of appeals actually are somewhere anything, people who get a premium above largely 800 all the way above, they tend to appeal. All right? Now, those people why they tend to appeal is because they are looking for the 500. Because it is obvious I would want to pay the lowest, even me. All right? Even me, I want to pay 1,000. All right? But I'm paying thousands. Now, what you need to look at is we are continuously improving the appeal methodology by starting to also deploy people who know you and can come into a facility. You are whatever, we have our CHP program. We have
health promoters,
the guys who do social protection in the ground. So we want to use all this government system to make sure that we reduce the error. But this error is not the error of actually largely overestimation. It's actually desire driven by the intrinsic characteristic of human beings that I want to pay as lowest as possible. Right? Even a guy who can pay. So it's a balance there. So if you just go ask anybody who is paying and they have not been sick, by the way, who are the people paying? That's another question you need to ask. And data is very important. Majority of the people who are coming to pay, they are at the hospital.
So already there's an advanced selection.
There's some advanced selection, right? Now, why we still have not introduced waiting period? You can go to hospital today, pay, and you are treated. Is because the population of 5 million households is large. So when it is large data, the error term reduces of that adverse selection because when you come and you make a commitment to pay for a year, that means you will not pay now and disappear. What the many people have been suggesting is to go back to the NHIF old days, and we must learn from experience. If you tell people contribute a month, and they don't make a commitment to pay for the year, they will come pay 500 shillings. They will claim 100,000, they'll disappear.
Disappear.
Where will the money come to pay for the others? So to equalize, that's why there's leadership on the body. So you make a commitment that I'll pay 500 years. And my cover will keep on today because I am getting into a very large pool. All right? Then that large pool, even if my premium is 600, actually, majority of those people, the money they want to consume is more than that.
Of course.
All right?
Of course.
Now, so we are continuously bringing young people, non-sick people into the fund, the healthy, and as we do that, then the benefits continue to increase. And the question is, are they increasing? It's a very important question.
Are they?
So we started, for instance, imagine ICU was 4,000. Okay, NHIF used to pay nothing. Just to highlight to you because people get into that confusion. NHIF for the national cover had 0 for ICU.
Unless
SHA,
you find your way and talk to a few people.
Yeah, that was a crooked system. So SHA came and started paying 4,000. People say, it's very little, but it's from 0. The 0 was good, but the 4,000 is not good. I want to show you how reporting goes. Do you know how much they pay now?
28,000.
28,000
per day.
Per day. Now, why aren't we seeing that this is a good progress? It will happen to the others. But if we started with 28,000 without collection, what will you do? The facilities will provide service, but they will not be paid because there's no money. We get like the debt we accumulated, we are struggling with now of NHIF.
But
and the last thing is that we have a very transparent system. And that's why we have afya yako mkononi. So that if you find you have been billed for something you have not accessed, why you have afya yako is so that you see it, so that you complain, so that you take responsibility of your benefits. Because we can preach how we want to be good, but we still have log facilities. We also still have log providers. All right? We cannot also make this few log determine our healthcare system. So it is the patient, the provider, and the insurer. They must work together to secure better benefits for this mean tested amount.
So, and you've actually gone to what I was going to ask next, and maybe Abdi, you can address this. We deployed some of our journalists to various public primary healthcare facilities around Nairobi, in the greater Nairobi metropolitan area. And some were charged 20 shillings to open a file, somebody else 100. I think there was somebody else 1,000 for medicine in the pharmacy. And this was for primary healthcare because, some were even just taking their kids for regular checkup. We've had a situation where in an emergency, somebody was charged 520 shillings in one of the national referral hospitals to open a file. Yet, looking at primary healthcare and emergency healthcare, it's tax funded. I just need to be registered and I should be able to access the services without paying anything.
So yes, it's true. There are providers who are not yet applying the rules as expected. Yes, we have had challenges in terms of our transition for staff at SHA. From now onwards, as a payer, we do pay, and there are certain contracts that we have with providers that are very clear in terms of what is expected. So one of the things that we are moving into is to see, are the contract terms being applied as it is? So there's nothing called opening files.
I was wondering because
we have
everything
moved
is digital.
from, yes.
Actually, someone given, you remember that half exercise book?
So I'm sure when you have gone to those facilities, they did not give you any exercise book.
No, there's one who was given a half exercise book.
Oh, okay.
Yes.
A public facility?
Yes,
or?
yes, a public facility. And it's the watchman at the gate who's giving you once you pay your 20 bob.
Oh,
Kitabu
okay.
imekatwa katikati.
Now you see, those are the issues that we are addressing with the help of the Digital Health Agency, just to make sure, is this facility really on the HIE? Are they being issued with the tablets required?
After
they
that,
have-
actually,
Yes.
once they paid the 20 bob, they were given the half book.
Yes.
Everything else was digital.
So
Everything else was in the system.
So that tells you that it was not true.
So where is the
It's
so
a
where is
very
the
wrong.
20 bob going?
Exactly. It's a very wrong facility. So they are selling books, in other words. To be honest, how else would you explain, I give you something that I'm not going to use? So I'm telling you, use that exercise book for your child to do some writing, scribbling, because there's no justification. And if you were to ask the facility in charge, what is this for? Because you have captured everything else digitally. What am I supposed to do with this exercise book? And these are the things that we also want the public to speak about and point out those facilities so that it makes our work much easier and take the necessary actions. And for sure, you might find it's localized. In that same county, you will find other facilities which are the same level, either dispensary or health center, doing the opposite, not asking you anything, treating you and releasing you. So you ask yourself, why is one facility within the same county? So then it's what we said, in every society, in every group, you expect a few to be the rotten ones. We just need to call them out, to say, here there's a problem, so that we take the necessary action. And more importantly is the committees that have been formed to oversight those facilities. The population around should be able to speak up and say, in this facility we have a challenge. They are asking us to pay when we know that they shouldn't. We are not supposed to pay a shilling. And we have time and again, I think His Excellency the President has spoken about it, the CS has spoken about it. Do not pay in public hospitals for PHC. Do not. Repeatedly. But
Some facilities, they just prompt you in M-Pesa. If you don't pay, they don't see you. You're just kept waiting.
And that's why we need to take the necessary action for those facilities. You point them out, you report them. I wish these were,
We'll give you the names.
they were reported regularly in the same media, the way we would want to hear the wrong facilities,
We'll
so
give
that
names.
we take the necessary action. And this program cannot work from just the SHA perspective only, as the payer. We need to work in collaboration, the patient, the provider, and the payer, and government in terms of the ministry and counties. And hence why each one of us is held accountable on what they need to do. For me, I have promised I will pay for services. The provider has accepted to say, I will provide these services, and he bills me for that. You have paid me, or government has paid me to pay for that services. So each one of us must play their role correctly. If they are wrong providers, we are more than happy to get rid of them. That's one thing that we will not hesitate to do. We have close to more than 10,000 facilities, and we don't need 10,000 facilities, to say the truth, because there are too many to begin with. So the few rogue ones, will get rid of them out of the way. But where it's now that we would say we are settling, even at the branch level. Previously, you have had that challenge of where do you go and address. Now, in every county, there's an office that you can report to. There's a team that's willing to do the surveillance and walk through to the facility, find and check out whether that issue of being given an exercise book is happening, and take the necessary action. So there is a lot more improvement in terms of how providers engage with the patients that we need to improve on. But we require the public to report also to help us hasten the process so that we take the necessary actions as quickly as possible.
So speaking of providers, there are also certain reports that, like Mwai said, the tariffs are gazetted, if I'm being admitted to replace a hip, it's X amount of money. If it's a medical issue, it's X amount of money. But then they say SHA is paying something like 13,000, 40,000, something really small, almost 5-10% of the entire bill. How come? Yet the figures are there, and it's
what they are doing, in other words, is they're taking advantage of your ignorance, because they know that you don't know how much, and that's where we also need and by the way, it's not all providers. The bulk of the providers will tell you exactly how much they are receiving from SHA, and you are supposed to receive a message, which shows even the amount, 350,000. So if the provider tells you no, it's 50, then you have a basis, because not everybody is able to go and read the tariff. For you to say, okay, no, it's 350,000. Why are you saying it's 50,000? Again, report, and so that we also know which are these facilities that are rogue in terms of services that they are supposed to provide. And hence why we need the help from the patients to inform us on the few who are not adhering to the rules and the contract that we have signed. So it will take some time before we get rid of all these kind of facilities. And it will also take some time before the public also know all the necessary information.
What their rights is.
Hence why we appeal to the media. The basics, just to help us educate the public to understand. And it doesn't mean that when I say that I have to take commercial advertisement for me, for you to educate the general public. It is for you to also make the public understand their rights. And it's for all of us in the long run. Because today you might be employed formally with a private insurance being paid by your employer, and then tomorrow you are jobless.
You're in the category
of informal who will
can't
be
pay,
complaining about the 500 or 600. So it is in our interest that this universal health cover works. And the only way it can work is if we work as a team. Yes.
Okay. The KNBS data, I was just trying to look for it. I think they put the consumption of SHA over the last year at 158%, meaning you need to pay more than you have collected. Why?
Yeah, so I actually don't think they are completely long. When you look at the period through which they reported, we can't have had a bill of 90 billion, generally, given our expenditures per month, which would range between 5-6 billion or something like that, so to speak.
So that's around 60 billion.
That is, full year, but SHA was not even there for that full year.
It was 9 months.
That period, SHA was not there for full year. So that's what you need to first understand. The second thing is that they took a report. You see, each report is designed for a different purpose. Like the way the mean testing report was designed for improvement of the mean testing before rollout.
All
right? That's the essence. All right. So you must identify correctly the problem and deal with it. Now, on this one, there is something called IBNR and something else called OCR. Yes. IBNR is incurred but not reported. It's an assumption you take. What could be out there? All right? But when will that claim come? It will come over a period of a month or so or a time. As it comes, you are also collecting money. So if I tell you that what is not incurred but probably is not reported, is a standard reporting procedure. So you make a provision, you assume.
It's an accounting.
All right? Now, that assumption is designed to make sure that it also shapes how you do your resource mobilization going to the future. All right? So that it is incurred but not reported. So you make a provision. But what I wanted to say is that the money they reported was not the true picture. And again, SHA is new, and I'm starting to believe health financing is not as simple and obvious as I thought. And I think it's because I spent my entire life on this journey on financing. And therefore, people just take numbers, interpret them based on their own knowledge, but they don't seek to understand what do these numbers mean. So when they report, I just see a number, I report. All right? So when you bring on board incurred but not reported, it will be reported. But this is a social insurance. Mm-hmm. What is the characteristic of a social insurance? It's mandatory, and it collects resources every month. Mm-hmm. So even what you are calling correction is for what has already been, has been submitted, right? But over the period of time, as months go, every month you will collect the resources. So the gap that is estimated then, if you use those terms, then you'll always find a very big gap. But it's because you have not gone to the month for correction. Right? So that's where the numbers are in. And there are many other numbers that are not,
So what is the current and true position in terms of collections versus payments?
The SHA has released these numbers every time on how much they have paid. As of the last one, I remember was 132 billion, if I'm not wrong. Chairman could confirm. Yes. Against a correction of 100 total resource base of 169 billion. I think that's the last.
So a difference of 37 billion.
So it doesn't mean that there is no money, all right? And there is also another thing that is no longer reported, that SHA has not paid providers. When you look at the data, which we do every time, SHA has paid between 68% and 80% to hospitals, on average.
The payout ratio.
Payout ratio, if I may, all right? That is for claim that should be paid. Now, there is claim that should not be paid.
Which one is that one?
They are called rejected claims. A claim is rejected because, one, it failed the access rules, all right? You come, you give, a man give birth, and I have submitted the man give birth. And SHA,
and theater notes.
Yeah. Then the other thing is the claim form, which you know very well because you are a doctor. The claim form is signed by one person. It's filled by one person. They are the doctor, and they are the patient, and they are the hospital. You see, now we have an AI-driven system. When you identify this claim, what will they do? Reject it. But now people get out here and make a lot of noise on claims that are rejected, right? Now, claims are rejected. This showcase that the system is actually working. In other times, those claims were being paid, right? Now, if you bill one patient in several facilities, all right?
It'll be picked up. It
will be picked up, definitely. It will become rejected across those facilities, right? Now, when this happens, people are starting to see, I think this system is serious. We saw facilities that had as high rate of rejection as 16%. The same facilities have come to 2, 3, 4%. The same.
Yes.
Because when you allow a human being free range, you just get in there the way you come, then you don't provide clinical notes. You need to be paid because we fear the public will say, we'll be told we are not paying. somebody comes, sign, is a patient, is a doctor,
Is
is
the
the
hospital
owner of the
administrator.
facility, we pay because you fear that people will say you're not paying. When somebody is reporting not paid, let them report not paid of what should be paid. Rejected is rejected, will not be paid, definitely. There are mechanisms of appeal which are set out in the law. They should follow those ones. But the Kenyans should also be educated. And you see, that's why I'm telling you, we need to educate our people, and the media need to become more proactive in helping the country grow. You know, as country take off, people must take a decision to help their country to take off, even if it's not for money, right? Because I do believe that majority of these people who are punished for false engagements have resources, actually pay, and they pay some of these log medias. But there are some that are very good, just to say. So focusing on the good ones, the good media should report in a way that the people understand their responsibility, so that when a claim is rejected, you should know it's not SHA who has a problem. We should make sure we know it is a facility that was trying to steal using you. And if you are a court, or if information is supplied to you, like if you are sent a message that you are trying to consume some services, and you have received the message, and you have not, instead of thinking that SHA is erroring, remember SHA gave you that information, so that you triangulate it and tell it, SHA, hapa kuna mwizi, tushike pamoja. That should be the thinking, right? Because that's why you have been even you know that afya yangu app. Kwa nini iko hapo? Sababu you want, when I receive the service, I can see it. So SHA has another eye in terms of the person who the person
the
getting
beneficiary.
care. Sasa huyu beneficiary ndiye anapaswa kusema na hii mimi si yangu.
Si mimi.
Wewe SHA hapa tunaibiwa. That is the language. It's not SHA is stealing. Stealing from what? The money is going to the hospital anyway. How is SHA benefiting by paying a hospital for something that was not done? But information is provided to you kama Mkenya ili usaidie uweze kusema na hapa SHA tuko karibu kuibiwa na mtu anatumia jina langu. Say it. Then SHA crosses the system in a way that one day you will open up the afya yangu app with the confidence, the same way you check your M-Pesa balance. You know, ukiona M-Pesa balance, you know, this is looking like it's mine. You know, they go to check how many have I sent, where. You get to, you build trust. Trust is built over time.
Yeah.
So this app, our desire is that as SHA now, you know, SHA, by the way, and I don't speak much for them, but I look at what they are doing every time, is because SHA had no staff. SHA had NHIF staff until recently, right? These are people who the World Bank report, the report on the NHIF we want, had said 60% of those people, they are not fit for the purpose they're employed for. Now, are we thinking that we will see miracles within the first few months with those people? No. Now, after you bring on board, and now chairman and team have hired, and I want you to look at the profile of the people who have been hired in SHA. I feel very happy as an observer from outside here and as a Kenyan that they have the right people. Now, when the right people come, we should help them to do the right thing because they have capacity now. Earlier, even if you try to help, they had no capacity. All right? Now, they have capacity. They can do it. They are actually doing it. But I just want us to tweak, because I see, like, when I am relaxing, I look at social media and I see somebody is very bitter with the SHA because they have been supplied information by SHA. I don't know if you're getting it.
I've seen that.
Even majority of the people who are reporting the things SHA is actually doing or not doing is actually information provided by
SHA.
Sure.
Even when the list of those who have been paid, you know, you can publish, and I am still there. I believe that SHA should be able to publish money paid to hospitals because it's public money, all right? And when they were doing that, you would find that people saying this facility died, all right?
Yeah.
That is the essence. because that's the way you clean up. If it is
system.
died, they will go and check, how did you bill when you died? Then you investigate, you follow, you prosecute, you recover your money. It's through surcharging or...
And
or,
those
or,
that were closed,
or-
actually.
Yeah. So what I want people to see and to understand is the majority of the information people making noise on is actually provided by SHA. If they wanted to hide, they can refuse to publish who they provided. They can refuse to send you the message of services you have accessed. They can block your Yango app. Right? So, but we are not saying these things because we have some sensational guys who just come and pick something and blow it up. Right? But the desire why it was pushed out is for progressive people to interrogate this information and become part and parcel of building a social insurance that they can trust and they can love. The last thing is that everybody will get old. All insurances exclude you when you grow old. There is only one that doesn't care. They tell you, come baby as you are. Right? Okay? As you are. You are a Kenyan. Provided you are a Kenyan, please come.
Resident in Kenya.
Right? And you are a resident here, please come. There is only one. All the others, they will tell you, wewe umezeeka sana, you have many diseases, and therefore we will not cover you. If we will,
Pay.
tell me the premium. I want you, because you are also a very progressive lady, and I really respect you, Dr. Terry. As a progressive person, look at the benefits that the SHA is providing, including of the old people. Go and compare the pricing of the same without the private insurances covering, saying SHA is a basic, is a base cover.
No, the premium.
Actually, why they have moved to start covering is because SHA is the first charge. If you remove first charge, the private insurances for those old people, senior citizens, will actually be 200, 300,000. And you
It's
can
actually
check
very high. No,
that,
it is,
that,
it is.
and compare with other jurisdictions.
And they have exclusions and waiting periods.
Correct. So what I'm saying is constructive correction, constructive discussion, progress-based kind of thing. I think as a technical person, I love it. Sensationalization, activism, and those kind of things. As a technical person, I have no room for them. Because those are people who want to balkanize you to live at a poor state and never progress. Just for the few coins they receive from those who benefited from a dysfunctional system.
So in summary, we are suffering from providing too much information,
Being transparent.
being too transparent.
I have
Because
one
that
last-
is one other thing that I've realized. Even when we publish who we are employing, who is shortlisted, people complain. I'm wondering, I'm the one who's telling you, I've shortlisted the following, I've appointed the following. People are not used to that kind of
transparency
and information,
openness.
getting information.
So I have one last question for Mwai on the means testing, where I think it was one of our feedback from one of our audience is somebody is old, retired, they're living well because they have children who have, say they're even out of the country, or anyway, they're taking care of their parents. So when they do the means testing, they are probably living in a big compound, good house that is stone-walled, toilet in the house and all of those kind of things. So their premiums go high, but in actual sense, they are dependent on their children, so they don't have any active income.
So if SHA was not there and they get sick, who will pay the bill?
The children.
Correct. Will the
Out
bill
of
be?
pocket.
Will the bill be equal to the premium they will get?
It will not. It will probably be high.
Let's not, split hairs. This person is old. You have old parents. I pay for them. I've done mean testing. By the way, I've done mean testing. I pay for them. Majority these parents are living at us as children. Right? It's the same way. It's what is common within the African setting, for sure. Now, what question you want to ask yourself is, one, why do these people want to come in? Why do they want to pay?
Because
Because
they
there's no other
need.
cover.
Goja.
They need.
They are in need.
Because
What is the size of the need compared to the pool they are going?
it is big because they are high risk population.
But you are a high risk population. All right? Technically, you are a population who should be left out if we were to be in other jurisdictions or if we were to be at the private insurances. You would have been left out. So the government have said, well, I've paid for you primary health care. Okay, free. If that old person gets into an emergency setting, we will carry them to the hospital. We will pay for their 24-hour stabilization. In the meantime, you pay this thing. Okay? Now, you have been paying for your mother money for food. That's what you are saying. By the way, your mother have a car, which you fuel, but you don't want to pay a premium for her. That's what, you know, if you want to say. All right? So this person is a household by themselves.
Yeah.
We cannot say, because the law that created a household is the same law that created SHA, the same law that is used to pay for old people support. So this is a household on its own. All right? What is their source of income? It's support from the children, right? Okay?
It is.
Now, they want to support all these other things, but not the most important. So I want to just say, it is impossible to start asking a parent, now are you at the parent children support or this expenditure is yours? No. This money is yours. What you look at is, what is the resource base of this household? Right? More so a household of an old person actually should not make noise. Because they are a risky population. They will for sure consume.
Definitely.
All right, as data is very clear. And therefore,
Their consumption will be
their
times three.
consumption is far higher than the others. So I should not complain, surely, that testing value of
1,000.
800 or 1,000 has been given to me because I'll pay 12,000 if it's 1,000. All right, as support. And then when this person gets sick, which diseases are we suffering from? Because you know the epidemiology.
Chronic illnesses, diabetes.
We have diabetes.
hypertension.
You have renal problems.
Dialysis.
All right? But how much is this renal problem this guy paying?
It's $1 million.
It's $1 million.
$1 million in a year.
All right? You have cancer. How much is he paying? Almost 800,000.
880,000 in
All
a year.
right? Now, these are the diseases these people have. So I am complaining of 12,000 really
To get a benefit.
to get 1,800,000
million.
and all the chain of surgeries that have been published under the
Hip replacement
whatever.
of
So
350.
let's also not think that there is a laissez-faire kind of a system. Because the employed people are paying. You also want to support your parent. That's why you want to come in. By the way, nobody is forcing you to come in as of now. It's mandatory, but nobody tell you that you will not, you must get in, right? But people are getting in. And I can tell you progressively, we have seen high adherence of payment on SHA Polepole. I can tell you, we started low, people came in, they started, I will not pay, I'll pay. People on SHA Polepole, their adherence level is very high. Because Kenyans are starting to understand, I have a partner here who has listened to me. So sometimes what we get to talk about is what is not important. What is important, we also rarely get to talk about it. The little people who are suffering, I can tell you they know. And I want you to go to a hospital which is offering surgeries, and you tell me who is not a SHA member.
Everyone is.
Go there.
Everyone is.
So before
Or
we
dialysis
or any dialysis center and check, any cancer center, check.
All of them.
All right. So the debate that we should get into through the benefit package advisory panel is actually how far should we increase our benefits. Now that requires a very sober person. That's why we left the old way, where a politician would just say, add this one. Before the politicians say, somebody must do background, somebody must do analysis. By the time they are saying, they are not saying from their own understanding. They are saying from technically sound information and advice. And that is what is happening now. Now, the problem we also have is that people have a way of thinking that even if they are trained in any course, anthropology, for instance, but just you are a clinician, you have very serious advice on healthcare financing. Unfortunately, that's not the truth. There are professions who look at healthcare financing every time. How is it built? How is it sustained? How is it managed? I wish we'll get to a level where people who are not trained in that area would reason. Not only in government, but private and journalists. Right? All of them.
Today, journalists were taking strays.
No, not really. It's because to whom much is expected or is given,
much is expected.
You have a very critical role that you can play. But every time you wake up in the morning, you might make a decision. How am I to play this role? Do I play it for progress or do I play it to progress my nation? All right? Now, it depends on how you answer it. Some of it actually go to the moral issue as you answer it, right? Because the one for progress may not be looking very rosy, right? And the one that is not for progress may be looking very nice. Now, depending on your morals, your value judgment, every time you wake up, you can create or destroy, right? So that's why I'm saying you have a higher calling to go beyond the stomach, and devote yourself to the nation. That's what I'm just talking about. All right, and that is how you create. I look at all systems that have been built. The Thailand system, which I love a lot. All right, the NHIS that I love, I learned something from. All right, the Obamacare, which I love, I learned some few things from them. All right, now when Obama started, if you look at them, the biggest problem he had was the system.
The digital system.
Digital system. Go look at it. It's a public information.
Public, yeah.
So that you also know, when you are a human being, you also pose and ask yourself, am I facing challenges that human beings face? Ama niko na zingine za wanyama na face. Na mimi niko mwanadamu. You need to pose. So even SHA must pose and ask itself, are the challenges I am facing in line with evidence of what has happened to those who have gone before us? And these countries are well known. They had system problems. They had fraud issues. They had rogue providers. They have appetite for people to make more money. When you are sick, you have no choice. So a provider can exploit you anytime.
And they do.
That's where you need SHA to have arranged for you. But when SHA is fighting with a facility which is overcharging, you find some other characters, because of lack of understanding, they are with the facility. Right. The facility is overcharging. Something that is being sold for 1 shilling, it is being sold 20 shillings. All right, SHA is saying this thing, we have agreed you to sell at 2. You make double. But don't make 20 times. Now, this ignorant fellow is now with the 20. Pay 20, wait. Now, that's how you see that the education is one important thing, and we must all participate in actually providing it to the population, to the provider, and to the social authority, and any other player. And I think as health economists, we have also failed in disseminating some of these principles, so that anybody, you find some guy is trained in RAB, right? And has narrowed to specialized RAB, but now is a finance expert for health. The fellow does not even know the golden principles to follow. No, but he has an audience. So misread this audience completely. All right. So we need to reduce the information asymmetry, come together, get a better structured way of having healthy discussions, remove politics out of it. Because whether William Ruto is the president or whoever is in power, or the years to come, the financing principles and the rules has never changed. That's why the Giro Bill, if you read it, you come and read at of 2003. You come and look at the healthcare financing strategy around 2005. You look at the 2019 report on the NHIF we want. All right. You look at the health law They are consistent on the technical side. Right? But now what happens is, and when politicians want to, and also the pathway of growth. Kenya had gone to Thailand to benchmark on UHC how to start 7 times. When the Thailand Prime Minister came here, he said this: you people have been benchmarking years in, years out. Please don't come again until you start. Okay? Now, after you start, now you grow to the future. The only thing that His Excellency, the President William Ruto, have done has given technical people a chance, all right, to, 1, do the right thing, and 2, to start this thing, all right? And when you are starting, it is not popular. Because if it was very popular, everybody should have seen it. Even the ones that are going to benchmark 7 times, you would have just started the first time. It is not popular because it is not common knowledge. So there is information asymmetry out there. So you can choose your comfort. He would have done it, but he gave the technical people and he gave the country a chance to begin and progressively move towards achieving universal health coverage. So that's what I see in this journey. And I really hope that when everything is removed, more so politics, and we sit down as technical people, we should be able to engage, ask serious questions, ask how is this problem. I have not, by the way, seen somebody who go and take that report and come ask, can you tell us, technically, each of these questions that were identified in 2019, how each of them have been addressed? Each, not vague discussions. Like this one, how was it done? This one, how was it done? So I was challenging the chairman and the team. They need to have something like a know your universal health coverage agenda, right? Learn it across the medias that are progressive, right? Those that are not, just abandon them. Even when the cow is drinking water, there are frogs in there. So you can abandon those ones. But the ones that ideally want to help the country, I want the people to progress, have a coverage that takes maybe a week or 2. You take certain questions that are pertinent, that are causing some form of confusion, and then this is explained by the technical people, right? Because politics have its law, and also technical work has its role. Fortunately, we have all this. We have politics, and we have the technical. They must go together, right? Sometimes one may go ahead of the other, but we have to catch up so that people don't think that this country reform agenda is not founded on evidence, which is the contrary. The last thing, because we are also more exposed, look at countries outside there and those who have been studying our healthcare system and the reform going on, all right? Record their comments. See, they are expert out there. WHO, UNICEF.
They're actually impressed by what's happening.
Go and check. Everybody else is saying Kenya has done what no other country has been able to do. All right? And I don't want to take me as my word, right? You go correct, you go, right? Because I see you in serious places with serious people. Some I don't even access, right? So ask those people. Because sometimes, because of the disadvantage of closeness, all right? And that we are in a system where people don't believe things can happen. They are shocked that they are happening.
Low trust society.
Right? Trust is very low. All right? It is also good to see why are the others wanting to be like us. I saw the CS with the minister from Ghana. All right? I saw the Zambian guys coming here. As people want to come and learn from each other. Why? It's a question we should ask ourselves. And might we be wrong in thinking that this system is not right? So it's good to balance these voices so that the chairman, you said that 100,000. You see, like 100,000 is not a lot. The way of seeing you talk, 100,000 of income per month you are seeing is low. Right?
It's high. It's low.
The way I could read it from here. But if you look at the population that is getting above 100,000,
very few.
It's very
Very.
All right?
Yes.
You would have barely 375,000, so to speak,
Yes.
above in terms of households up there, right? In the informal sector. Getting the money, you might think 375 is very low in a country that has that kind of
12
population.
million households.
12
we're
million
talking
households.
about. But you see, you might say, 100 is little, right? So it's the same thing. By the time people get to say this system is not right, we should go to the government-funded system.
Go back to NHIF.
We should go to NHIF. One, that's how I know they don't know NHIF.
Yes.
If you want to know somebody who does not know NHIF, it's just a guy, like, I want to just give you an example. Porcupines, they don't throw the spines.
Yeah,
they don't leave the body.
Yeah.
But when you hear people seated down somewhere in the village, they'll tell you, your aloe ilitoka mchale. Yeah? Mchale ilitoka when the animal was moving. Yeah? And I was hearing the sound. The sound is produced a sound like do-do-do-do-do-do. So you might think the aloes are coming out. So I used to tell my friends, close friends, if you ever find somebody telling you the porcupine drew a spike, don't proceed from there. Conclude they have never seen it, they don't know it, they don't know what they are saying. If you ever meet somebody who's telling you NHIF was better than SHA, then you should know they don't know it, they have never seen it. What they are saying are things they have heard. They are stories, like the way there used to be augurs that had the mouth in the back. Those are the kind of stories they are hearing. But if they have experienced it and they have looked at the characteristics, then they would go to the book written, the NHIF we want, of 2019. They would read the law of 2003. They would read the healthcare financing strategy.
2005.
All right, 2005. They would look at all those things. They would ask themselves, was NHIF this? They will come to SHA. They will say, is SHA?
Yes.
So there are 102 issues. They don't know NHIF or they don't know SHA. Yeah. That's the only problem.
One of the two.
One of the two.
Okay.
Thank you.
So finally, there's one thing that I keep on hearing about. This was my bill. This is the amount that was paid. And this is just to educate the general public. If I give you an example of 3 women who walk into a hospital, all have a benefit of, let's say, 100,000. And then all of them are treated by the same doctor. They undergo the same treatment, the same medication, but they move to different departments or wards in the same hospital. One goes to a general ward, one goes to a semi-private or private, and then one goes to the extreme luxury, the presidential suite type. When they are done with their bill at the end of the 3-day stay, all of them gotten the same treatment, by the same doctor, the same medication,
hospital.
the same hospital. The payer pays 100,000 for this one, and it's enough, and they walk out. The one who was in general ward. The second one, they say, no, because you are in private, you can only pay 100, but your bill, your invoice says 200. And then they say, okay, they have paid 50% of my bill. Then the person who has gone to the presidential suite now has a bill of 500,000, and they are only paid 100. They will say,
Paid 20%.
20%. So in all those people, they all have gotten the same payer, the same doctor, the same treatment.
Same hospital.
But the payout ratio for their all invoices is different. So for SHA, you don't just shout and say, only 15%. We have gone one step further. We have published our benefits and tariffs. In that same benefit and tariff, you can get different hospitals who will give you the same services within the limit outside the limit, and some extremely. So that is also a choice patients make. So you can't say it did not work for me. Imagine if those three women, the person who was in the presidential suit and said, oh, it did not work for me. That is how, when I see those kind of noises, I see someone who has not understood what is it that they were entitled to, what is it that they were paid for, and is there any other person who is getting the same services getting paid for fully?
So the thing is, as a citizen, as a Kenyan,
yes,
I should go to the hospital where SHA pays everything 100%.
Exactly.
If I don't want to top
If
up
that is
anything.
what you want.
That's what you want. But because you have a choice, you see, these three women walked into the same hospital. One said, okay, general load, I'm okay. I will share the washrooms,
amenities, everything.
with but they are being treated by the same doctor. The same medicine. Nurses are the same. So, but because of choice, which we don't want to be policing and limiting you, we allow you to take that choice. So when you make that choice, it doesn't again mean that you come and say, oh, you do not pay for me 100%.
So you're saying choices have consequences?
In a more simpler terms, the choices you make are the ones that determine whether your cover is fully or it's partly or it is... that is the message that I want people to understand. And that's why you will find in that same thread, someone else will say, but I was paid for fully. Meaning they have different experiences based on their needs. And certain benefits cannot be paid for the same as the others. For example, there is a certain surgery that we pay $1 million plus. $1 million plus, cardiac surgery. Done in Tenewek and some other private hospitals.
Even valve replacements I've seen, pacemakers.
Yes.
All of that, yeah.
The amount that we cater is $1 million. But there are certain surgeries we will pay 30,000.
Like a cesarean delivery.
Or a lipoma. So then it means they are not the same. Both of you, we have paid for you surgeries. But that doesn't mean we like this person more than you. It's just that that's how the benefit package has been designed. That which one is catastrophic. A choice of extreme leisure is not catastrophic. That's a choice that you have made. You want a room that has a sitting room. It's a choice you have made.
Luxury.
Yeah, it is something that we cannot force you to say no, that you don't need it. Please go for it. We have no problem. There's a reason why they were made available by these hospitals.
Thank you. Gentlemen, thank you. We have a lot that we can talk about, but we will welcome you next to see what else is happening around SHA, to have those conversations. Thank you. I feel like this was partly a class on statistics, on economics. We needed a short course on that. But thank you very much for your time this morning to have these conversations. And hopefully our audiences have picked a thing or two about SHA. If you have any other questions, any other concerns, please feel free to share them with us on any of these platforms where we are posting this, so that we are able to, submit that to the team at SHA. We'll be able to collect all of that like we've done with this and have those conversations so that we are able to understand a lot more what's happening, what's all right, what are the issues, what are the developments. Because at the end of the day, SHA, like Mwai says, is all ours. So we choose either to be progressive or retrogressive. And I think that's what I've picked from here today. So ours is really to try and get as much information out there for you to make. So gentlemen, thank you very much. Dr. Abdi Mohamed, Chairman of the Social Health Authority, and Dr. Daniel Mwai, Professor of Health Economics from the University of Nairobi and the Presidential Advisor on Health in Kenya. My name is Dr. Mercy Korir. Keep healthy.